1 in 8 men will develop prostate cancer in their lifetime. And this weekend, the University of Kansas Cancer Center and the Royals hope to strike out future cases. We team up to share the importance of screenings and treatments available. Coming up now on the Morning Medical Update. And good morning to all of you. It is Friday, June 10th. Thank you so much for joining us here on Facebook, YouTube, and on Twitter. Coming up, members of the LGBTQ community can face barriers in healthcare that they need. What can be done to help close the gap and be more inclusive? Also, Dr. Dana Hawkinson will join us with the COVID count here in just a few moments. But first, the American Cancer Society says early prostate cancer can have little to no symptoms, so millions of men may have it and not even know it. But there's a high survival rate when you catch it early, what you need to know. So make sure you get your questions sent in to us here on YouTube, Facebook, Twitter, and email us at the Medical News Network. You can find links to all of those right there on your screen. Cancer, prostate cancer, it is the second most common cancer among men behind skin cancer. This year, an estimated 268,000 men in the United States will be diagnosed with prostate cancer. That's according to the American Cancer Society. The average age at the time of diagnosis is 66 years old. But if caught early, the 5 and 10-year survival rate is about 98%. A live look now near the sports stadium complex where the Royals and the University of Kansas Cancer Center will focus their attention on prostate cancer this weekend. Sunday is Prostate Cancer Awareness Day at the K. Folks from the Cancer Center will be at Gate A. They'll answer some questions, and we have 3 specialists with us today to start that conversation now. Joining us this morning virtually is oncologist Dr. Elizabeth Wolfe-Birchfield, urologist Dr. Mobin Mirza, and also radiation oncologist Dr. Shinli Shen. So good morning to all of you. How are you?
Good, thank you. Good morning.
Great, good to have you. Great. Okay, so Dr. Mirza, let's talk to you first. When you hear that number, 1 in 8 men will develop prostate cancer in their lifetime, it's a number that makes you kind of wake up. Tell us why so many men get it.
I think that's a really difficult question to answer about why, without going into genetic basis of cancers and so on. But I think for our patients and for our communities, what's important to understand is how we can understand where this number is coming from and what the risk factors are involved that eventually put patients at risk and diagnosed with prostate cancer. As men age, they will develop prostate cancer. It's just a natural thing that will probably happen to all men. And as risk factors like age, race, genetic histories, family histories apply, we will find more and more men will develop prostate cancer. So those are some of the main reasons why it's such a high prevalence cancer.
So many factors, so hard to avoid. Dr. Wolfe-Birchfield, prostate cancer can have little to no symptoms, as we mentioned earlier. Most cases are in people that are well over the age of 40. So what should people look out for so that they can seek that early treatment?
Well, if men develop any new urinary symptoms, that really deserves workup. And of course, there can be stigma around these sorts of issues, but we in the medical community really want patients to know that their symptoms are valid and that we will approach them in a non-judgmental way to get them the answers that they need and that they deserve. And certainly screening is an essential part of prostate cancer sort of quote management, because it's really looking for red flags and can get men an early diagnosis in order to get them access to the latest and greatest treatments. But I would say any urinary symptoms should be a prompt for workup.
Now, we're really going to focus on screenings today because that is the key before you even have to get treatment. So we're trying to help you keep from having to even seek the treatment if you do need it. But I do want to go back to something you mentioned. You brought up the word stigma, and I want you to just kind of hone in a little bit more on that. And I want to hear from all of you about, and maybe Dr. Shen, you can get us started, just how do we break down that stigma when it comes to men's health in general, and certainly a screening like prostate screening?
So prostate cancer, very personal issue, right? Mm-hmm. Because it's part of our reproductive system. People have a certain reluctance to talk about it and to maybe undergo treatment. I think awareness, like things like we're doing, our prostate cancer screening is a blood test. We get blood tests all the time, right? Having that information doesn't mean that we have to do anything. Having more information allows us to make good decision makings. but it's not an invasive treatment. It's not an invasive test. And so I think there's a lot of misunderstanding, and people are afraid to approach the question, right?
So is there a difference between the prostate exam and the prostate screening? You said blood test, but
Yes,
that's not
absolutely.
what we think of when we think of prostate exam.
Absolutely. So there's a lot of reluctance, if you will,
Sure.
to undergo a digital rectal exam, right? And that's part of traditional screening. But we know that if you had to choose one test to do, you would get a PSA test.
I want to talk about
Right.
PSA, and I want to hear from everyone, but tell us why that's such an important part of the screening process.
Well, it's cheap, it is effective, right? It is painless. Well, one tiny poke. But we're getting blood draws all the time for different things, for our cholesterol, for our diabetes. One more tube of blood will find your, will tell us where you are with your PSA. Will tell us if you're going to have a high risk of cancer later, or if you already had a high risk of cancer. It is a very easy test. No, we don't have to do any, kind of invasive, rectal examinations.
You could say it.
Yep. Right.
Just just say it.
It's
okay.
You don't have to do a rectal exam. Just give us a blood test, and that will give us 80% of the information we need.
So let's talk about what is PSA? What is that finding in the body?
Sure. So PSA stands for prostate-specific antigen. It is a protein that's made by the prostate gland. And as Dr. Shen was mentioning, the prostate gland sits pretty centrally to our reproductive system, and it sits in a very carefully placed idea around sexual function and urinary function. As this protein is made, the semen that comes from the seminal vesicles and the sperm that comes from vas deferens is processed by this protein, and it helps it survive and help in reproduction. So it's a pretty critical protein. But when it's high, it can be high for many reasons. That could include infection, inflammation, injuries to the prostate. But under normal circumstances, if it's high, it indicates that there is damage to the prostate gland, likely due to cancer, or one of the potential explanations would be cancer at that point. So it's, like Dr. Shen was saying, pretty simple test to do. It's a blood test. It's easy to interpret. We have years and years of data on it now to be able to understand how to interpret it, how to look at it, how to figure out next steps.
So how long has it been around, doing this blood test?
At least since the mid-'80s to late 80s, yeah, a long time.
So Dr. Wolf Birchfield, talk to us about this test, because I think, again, I'm trying to just play the mind of the typical person out there, because when I think of a prostate exam, that's what I'm thinking of, and maybe that's why men don't go get it. So how helpful is it for them to understand what this blood test is, that it's available, and it certainly could be a good first step in getting somebody through your door, right?
Absolutely. We certainly hope no one in our audience needs any of us, because we don't want people to be diagnosed with any cancer. However, knowing that catching prostate cancer early can result in incredibly good and successful outcomes from treatment and cure, early diagnosis is key. So my perspective on PSA is that, or on prostate cancer screening, is that if we have only one tool, then PSA should be it. And I think if our viewing audience is willing to commit to follow up with their regular primary care provider or urologist in order to get that testing every year, that's the most important step, and that would be a huge accomplishment. So I think we just want to raise awareness for men's health as part of that, and also encourage folks that while it's scary to think about screening for cancer, outcomes can be incredibly positive and successful.
The New England Journal of Medicine reported that African American men are 73% more likely to get prostate cancer. Dr. Shen, why is that, and how do we get that number to change?
Yeah, so that's incredibly important. And I think one point I want to emphasize about there's a difference between African American men and the rest of the population. If you look at screening guidelines, right, African American men are asked to be screened at age 40 as opposed to 45. We know there are certain genetic differences between African American men and the rest of the population. And African American men have cancers which are more aggressive, diagnosed at a later stage, and even stage for stage, they have worse prognosis. So, if you look at, there's a big study out of JAMA a year or two ago, looking at patients who are diagnosed in the VA system. where presumably everybody had the same level of access to care. Stage for stage, African Americans did worse. And so I think it's important to get screening, obviously, but especially for African Americans, I think it's important to get screened a little bit earlier.
What concerns you most, certainly coming out of the pandemic, Dr. Mirza, about people getting their screenings? I mean, we know in cancer, people were putting them off. Are you seeing any of the effects of that so far?
Yeah, I think certainly we are, and definitely on an individual basis. We'll see how it sort of defines the rest of the population later on. But I think a lot of patients postponed their care during the pandemic. And some of that made sense, obviously. They didn't have access to hospitals. They wanted to avoid hospitals. Or we weren't allowing some regular visits to go on, just the challenges that we had in our own medical systems. So some of that care has been delayed. From the screening process, yeah, we've seen patients in our clinics where, hey, they were doing okay or never seen before. Now all of a sudden, within their follow-up, it's a year delayed or a year and a half delayed, and things have changed. And now their prognosis is worse because we didn't catch it in time or we weren't able to do the studies in time. So that's a reality we're facing right now as we catch up from the patients who were not seeing us in the pandemic who are seeing us now. And I think it very much applies to the population that's being screened for prostate cancer and other diseases as well.
You know, we kind of, in society, we kind of tease that men don't seek medical care, or their spouses or partners have to be the one to push them to do that. Is that true? I mean, are we seeing men take more control of their health and put themselves first and say, you know, regardless of the stigmas and different things, it's important to make sure we catch things early?
Yeah, I think maybe to some extent men are taking more charge of their care, but I think in general, I think all of us who are oncologists here, when we sit down in a room talking to patients, and there's a man and maybe his wife or his daughter in the room, the person most concerned is not the man. And they maybe internalize it, and there's sort of a huge psychological aspect there that is sometimes really hard to read. But yeah, men in general try to avoid invasive care. They try to avoid difficult discussions. And I don't want to stereotype all men, obviously, but this is what we observe in our clinic. So I do think this is changing, and I think it's changing because we're doing awareness events like this. Physicians in the clinic and community members, neighbors are talking to each other more and more. We have more social media access, and you can say, oh, maybe I should get this checked out. And it's pretty amazing. Once a man starts opening up about their symptoms or about their concerns, it's very revealing how much deeper you can get into the issues that they're dealing with in their own mind and in their own health, and then we can help them a lot better.
And you mentioned social media, a lot of negatives to it, but it's nice when you hear people share their stories. It definitely helps people come forward.
Absolutely.
And know that they're not alone. Dr. Wolf Birchfield, just your insight, what are you seeing in your clinics and hearing from men and their partners?
Well, I do have a lot of men who are treated for prostate cancer in my clinic, and of varying stages. We have a lot of really innovative treatment at the University of Kansas Cancer Center, and that means that sometimes patients are meeting me as a medical oncologist who prescribes medical treatments earlier than in the past due to innovation. But you know, I do think social media does help raise awareness for issues that have previously had stigma, and for that I am personally grateful. And I haven't really seen any different mix in between my patients and their support persons during this time, but what I've encouraged, and when folks come to see me, I encourage their loved ones to get their own cancer screenings, and I've encouraged patients and their loved ones to just give themselves screening amnesty. If it was missed because of the pandemic, just realize that was part of a bizarre time in our history and commit to it going forward, and know that you're doing something good for yourself by doing that.
There's something good about getting your screening. I got my mammogram this week, and there's something about just walking out kind of going, yes, okay. And then before you know it, my chart, it was like, everything's okay. And there's just that feeling like you did something good for you and your family and those that love you. So I like that message. We're going to talk about treatments coming up in just a bit, but I do want to get to a community question that we have from Mary. And good to know, because she wants to know if men in her family have had prostate cancer. Is she and all of her female family members at risk for other cancers? Anything you can add to that?
I can chime in. So we know if you have a first-degree relative for prostate cancer, you're going to be at higher risk for prostate cancer. Historically, we've thought about prostate cancer as not really being that genetically involved, but the current information is about 10% of aggressive prostate cancers have some kind of genetic component to them. So a man with, say, the breast cancer gene might actually develop prostate cancer. It might be the first cancer they develop if they have the breast cancer gene. And so if we see a strong family history, it doesn't have to be prostate cancer. It can be prostate cancer, breast cancer, colon cancer, strong family history. I think these patients should have greater awareness that they're at higher cancer risk, screenings, and as well as their family members. For patients who are diagnosed with prostate cancer and strong family history, or even diagnosed with very aggressive prostate cancer, it is actually recommended that they undergo genetic testing, germline genetic testing, to see if their family carries some kind of cancer risk gene.
So my grandfather died of prostate cancer. What would my risk be, or anything that I should be looking out for, or just keep doing my regular screenings?
Keep doing regular screenings. I mean, that's not necessarily, if you had told me, yeah, my father had prostate cancer, his brother had prostate cancer, his sister had breast cancer, yeah, you might think about something more, more frequent.
More frequent,
yeah.
more aggressive on that part. Okay, we are going to get to treatments here in just a moment, but let's turn to Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, joining us with our COVID count today. Good Friday morning to you.
Yeah, it is a pretty good morning. Great discussion here. Also very good in the health system, in the hospital. We have 6 active infections right now, with 2 in the ICU, 0 on the ventilator, and 7 in that recovery period. So again, our active infections seem to be very low, continue to be very low. We know that in the U.S. in general, the number of cases has been fairly stagnant to slightly decreasing, and same thing with hospitalizations. So although we may be seeing more infections of actually that we're able to count, but other ones that we aren't able to count because people are testing at home or not testing, what we haven't seen really is that increase in hospitalizations, and that's always a good thing.
All right, thanks for the update. Couple of headlines I want to talk with you about today. So June 20th, that's this date, this magic date for kids under 5 getting the vaccine. Biden administration has laid out a plan for that vaccine for those kiddos. Is this a reality? What could that look like?
Yeah, I think it actually is, and I think it's a very good thing. We certainly have heard that the younger populations, we understand more and more that they have probably been infected recently, especially during that Delta Omicron wave or surge. We continue to have very good evidence and supportive evidence to say that if you get infected and then get vaccinated, you do have very good immunity. So I think moving into the school year and being able to protect those young children even more, and then of course those people around them by the vaccination, that's going to be a good thing. So certainly we'll wait for that. Hopefully the vaccine uptake is going to be very good.
Okay, 2 new versions of Omicron are gaining ground here in the U.S. That's according to the CDC. What can you tell us about that?
Yeah, so these are BA4 and BA5. These were originally detected in South Africa as well. Unclear exactly why and how. We know that variants arise. We know that South Africa has a huge population that is seropositive, meaning they've probably been infected. So this is just part of the viral evolution and just being able to infect new people just because of random mutations that occur. We know these variants have arisen because of that, but then found some sort of space or vacuum to infect people. We do know and understand that really infection with previous versions or variants and vaccination create very good immunity. We aren't as concerned about infection. We know that BA4 and BA5 now are increasing in the United States, but overall what we haven't seen is that large increase in severity and hospitalizations. We know in South Africa they haven't seen that as well, and so I think most of us believe that we won't see any increased severity. We still have those conserved areas on the spike protein that are identified by our T cells. Our T cells are really what is important to protect us from hospitalization and severe disease. So at this point, I do not believe that really anybody is too concerned with increased severity. Again, being vaccinated or previously infected and vaccinated is going to confer very good immunity to help reduce your chance of going to the hospital. But if you do test positive, especially if you're in those high risk, or you start to have symptoms, test early and use Paxlovid as well.
All right, let's get back to our talk this morning about prostate cancer and the different types of treatments that are available. Joining us virtually is medical oncologist Dr. Elizabeth Wolf-Birchfield, also urologist Dr. Mobin Mirza, and urologist and radiation oncologist Dr. Xinglei Shen. And I want to talk about an estimated 34,000 men will die from prostate cancer in the U.S. this year. And of course, if detected early, that 5 to 10 year survival rate is nearly 100%. So if caught early, highly treatable. So treatments are very, very important. So I want to talk about the newest addition here at the Cancer Center, Dr. Shen, our Proton Therapy, and how that works for prostate cancer.
Yeah. Oh, that's, we're really excited. This month, we just started our Proton facility. It is another option in our armamentarium. So, prostate cancer treatment, we have so many great options. For certain, I'm sure Dr. Mirza will talk about the different types of surgeries we have. We have a lot of great radiation options. The proton therapy is one of our great radiation options we have. It differs from traditional X-ray radiation in the sense that the proton beam goes a certain depth and then stops rather than going all the way through the patient. And so what that allows you to do is spare some radiation dose to some of the surrounding normal tissues, potentially reducing side effects in the long term. That is one of our options that we have. We also have brachytherapy. We have stereotactic body radiation. There's a lot of different options which may make sense for different patients. But proton therapy we have it available, and it is certainly an option for our prostate cancer patients.
You said another tool, the toolbox. Yeah. Okay, so Dr. Mirza, I want to talk about this. I'm going to try to get it right. Rezia sparing prostatectomy.
You got it right.
Ah, yes. Okay, but you got to now explain it. So tell us about that.
Sure. Well, as Dr. Shen was saying, the crux in any cancer treatment is balancing the treatment of the cancer with the quality of life impact or the treatment burden that the cancer confers. So we're trying to always balance that, and just much like with any tool that we use in radiation therapy, the idea is to spare the quality of life and preserve things in the body that help continue the quality of life that the patient is expecting or is used to. With prostate cancer, the biggest impact happens to urinary function and to sexual function. So men really experience problems with these two quality of life issues after any treatment of prostate cancer. With the Rezia sparing surgery, what we're trying to do is preserve the backing of the bladder and the urethra during the surgery, anatomically preserving those things during the surgery, so after the surgery the patient does not experience as bad incontinence or sexual function problems.
So is the treatment what causes more of the problems, or the cancer itself, other than?
It can be both.
Okay.
Certainly, and sometimes when cancers are aggressive, treatments have to be aggressive, and then those problems become unavoidable, and that just need to be managed later. Sometimes the cancer is in a situation or in a location, and we use a lot of image-guided techniques, both in radiation, both in surgery, to preserve normal organ tissue, to preserve things around the prostate gland that can then reduce the quality of life impact later.
Well, and what you're talking about, I have to mention with your team, this is a very extremely specified training that happens here at specifically here in our region at our facility, right?
Oh, absolutely. I mean, I think for any new technology, newer technique, you have to develop a certain degree of expertise. So, yeah, I mean, it's not cookie cutter.
Absolutely. Let's talk about stereotactic body radiation therapy. This offers people a chance to get fewer doses of radiation. Who might this treatment be good for?
So, we are always evolving our radiation treatments. And one of those evolutions is, instead of doing your classic 9-week course or more, it's more standard now, like 5.5-week course, we can go to a 5-treatment course. It can be done in 1 week. Like every new technology, you evaluate it in the safest way possible. So right now we're offering, most people are treating this as standard of care, like regular option, not on a trial, not experimental, a regular option for patients with lower risk cancers. As we start moving into the future, I think this will become more of an option for patients with higher risk cancers. We have really good data that it is just as good, maybe even a little better, but at least just as good in lower risk cancers. And that data is going to come along and allow us to offer it to more and more patients with higher risk cancers in the future.
Dr. Wolf Birchfield, I guess this is where that statement, where you get your health care, really matters. When you hear of all these treatments that you are able to present to your patients, right?
Absolutely.
Talk to us a little bit about that. What we say where you get your health care matters, and that people are specified and training to be able to present these options.
Well, so what it makes a difference in many ways. Some of it is very technical, as my colleagues were describing, with specific knowledge about what radiation techniques are appropriate, what surgical techniques are appropriate. It also matters because those of us academic oncology, and whether it's urologic or medical oncology like me, we're really engaged in the international prostate cancer research and most recent data. So we understand as well as anyone possibly can what the best, latest and greatest looks like, and what the future hopefully is going to look like, and get our patients those treatments.
So this weekend, the Royals are hosting the Prostate Cancer Day at the K. Doctor, just tell us a little bit about why this messaging matters. Will we have people coming out to enjoy a great day at the K, but you're able to kind of get that captive audience and share a good message? How do events like this help?
They are so important to just raise awareness for this disease, the excellent outcomes that many and most men can expect, and the importance of screening. As we talked about, there is stigma around screening for some cancers, such as prostate cancer, breast cancer, and cervical cancer. I think really any cancer screening can, but we want to raise awareness for the capabilities that the modern technology has, that what we have at the University of Kansas Cancer Center that's specific and high value, and ways that men can access all of this care.
I want to get to a few community questions this morning. Jan wants to know, Dr. Mirza, should men over 80 still have PSA tests each year?
That's a very good question. I think, in general, our screening protocols or guidelines really indicate that past the age of 70 and certainly past 75, men should stop screening. Now, the exception to that rule is an 80-year-old man who's really healthy.
That's what I was going to say. People live longer now.
Yeah, absolutely. So I think for healthy 80-year-old men, I think screening is still reasonable to do, and I think it requires a good discussion with your doctor to say, hey, is this helpful for me? Where am I in my health? What are my risks? And then make a good decision about it. But yeah, absolutely. I don't think it should be a no to anyone. But as men age, we should be using our screening tools more carefully and having a more detailed discussion about it.
Dr. Shen?
Just one thought I might add to what Dr. Mirza was saying. I completely agree. All of our data, right? Everything we do in science is based on data. All of our data were gathered in the 90s when people were living to about 70 now. Now we're living to about 80. So, some of these guidelines were designed in an era when we didn't live as long. And so you got a great, healthy 80-year-old, and everybody in the families lived to like 95 and 100. Yeah, I think you should make sure that you don't die of prostate cancer.
Absolutely. Dr. Shen, Betsy wants to know, I understand that surgery is difficult after radiation. Is surgery still an option after proton therapy?
I think this is important for people to understand. Proton therapy is still radiation therapy. It changes where your dose goes, but it is still a form of radiation therapy. And right around the prostate is still getting a high dose. So it is still you still have some of those difficulties with surgery even after proton therapy. Not to say that you can't do surgery. I know for a fact that Dr. Mirza has done some surgeries after radiation therapy, and it is definitely more difficult, but it's not impossible either. But to answer your question, I think you'll run to the same level of challenge with surgery after proton therapy as after conventional X-ray radiation.
Such a great conversation today. Really important to remind people about screenings. I want to get to final thoughts from our guests. And Dr. Mirza, let's get started with you.
Sure. I think, for me, prostate cancer is very close to my heart. I started doing research in prostate cancer when I was in high school. My dad's had prostate cancer. My grandpa's had prostate cancer. And I fear in some realistic and scientific way that I'm going to be in my patient's chair someday. So this is very close to me, and I do my best. And I think we can only control what we can control. So I think for all of us listening, for all the doctors, community members out there, talk to your neighbors, talk to your friends, talk to people at your church, at your mosque, wherever you go. Engage with people about the importance of screening. I think this is very, very easy to do. It's an easy conversation. There are a lot of barriers like access, like what we understand about things, fear. Just having a normal conversation about these issues is very, very critical. So I would encourage everyone and their families to, screen for prostate cancer and be mindful of your health in general. Stay fit, eat healthy, exercise. I think all of those things are very, very important. I think we talk to each other about a lot of things, we talk about politics, we talk about COVID, and then the important conversations around cancer or cancer care or even just general health get ignored. So we owe it to each other, to our friends, our families, to be able to have these conversations and move forward.
Thank you for sharing your passion. We appreciate it very much. Dr. Shen, final thoughts today.
Yeah, you know, I think we can't, I'm so excited to be able to talk about screening and importance of screening and catching the cancer early. And I think we focus so much of our attention on survival, right? 10-year, 5-year survival, 10-year survival. And that's obviously, important, survival or not. But also you have to think about quality of life and treatment intensity, right? So if you get a prostate cancer diagnosed early, you need one treatment modality. You have surgery or you have radiation and you're done. But if your cancer is diagnosed late, you end up needing both radiation and hormonal therapy, or surgery and radiation and hormonal therapy afterwards. These intensification of treatment with delays of a cancer diagnosis really impacts quality of life. And so I think we shouldn't get lost in the just looking only at survival, but also looking at quality of life for our patients.
Well said. Dr. Wolf Birchfield, final thoughts. What do you want women to know?
Well, I'm just so pleased to practice in an era in which we have such wonderful tools and treatment techniques. And I do feel very strongly that we in the oncology community are extremely committed to helping men who get diagnosed with prostate cancer get the treatment that is best for them as an individual. And with such a big slate of options, we really can do that. So we are here to help meet everyone's individual needs and preferences and make sure that your healthcare matches that and that we get the best balance of cancer treatment and quality of life and overall well-being.
Thank you so much. And thanks for helping us work on the stigma behind getting those important screenings. Thanks for the work you do. Dr. Hawkinson, your final thoughts on this topic, so important.
I don't think there's anything to do other than continue to endorse and just echo what our guest said. Absolutely, I was thinking the same thing about quality of life. Please get with your medical teams. Prevention is the best way moving forward. This will help save you a lot of time, complications, all of those things if you catch it early. And it's preventive measures such as the screenings you talked about with your mammogram, but also the colonoscopy, the prostate. All of those screenings are extremely important. Also other preventive measures like staying up to date with your vaccine. So those resources are all out there. I know it takes time, but it's really just a fraction of time when you consider the long-term prospects. So please talk with your medical providers and really get those screenings in.
Thank you. In headlines this morning, last night was Pride Night at the K, and this weekend marks Pride Fest here in the Kansas City area. Our health system will have a booth and be walking in the parade. We are proud to be designated as LGBTQ+ Health Equity Leader since 2018. Joining us now to explain more what that means is Gigi Sears. She is Assistant Director of Professional Engagement here at the health system, and also Cancer Treatment Nurse Manager Chris Bain. Welcome to both of you.
Thank you, Jessica.
Thank you.
Good to see you both. Gigi, we've talked about this a lot. You've always shared the good news year after year. What does it take and what does it mean to be LGBTQ+ Health Equity Leader and status?
So this is a body of work, an assessment tool, if you will, for the Human Rights Campaign, which is the national advocacy group for LGBTQ+ folks. And it assesses practices, it establishes best practices and assesses our ability to meet those best practices in 4 main areas. One is about policies that show non-discrimination on the basis of sex, sexual orientation, gender identity, and gender expression. Staff education. The next pillar is patient and family support. That includes electronic health records that allow patients to identify themselves with respect to gender identity, pronouns, sexual orientation, specific instruction and practices on how we define family and what that looks like to make sure that we're inclusive. The third pillar is about employee support and policies, practices for employee support. And the fourth one is about community engagement. And I think that's the one that we're really speaking to right now is we've done a lot of work. We have great providers. We've put practices in place to make sure that we're not only friendly, I mean, that's the minimum bar for LGBTQ+ folks, but knowledgeable and competent, and we have the structures in place to support that great care that's provided. So We've given visibility and created structures for visibility for individuals. This week or this month is about showing the health system being visible to the community, that we are working very hard, always trying to get better, to provide great care and inclusive care.
Gigi, nice job, nice work to your team. Thank you for helping our organization get there. We appreciate that. Chris, how does discrimination lead to poor health? Help us make that connection, make that clear for us.
Sure. When people feel discriminated against, they tend not to seek care immediately or even at all. If people do not feel welcomed or they fear they're not going to get sensitive care, they're going to do whatever they can do to stay out of the hospital or come into the ER or seeing their doctor, which can create a delay in their care. And a delay in care can lead to poor outcomes. Patients may go undiagnosed with acute or chronic diseases due to being fearful about being seen by a provider in the urgent care clinics, to the ER, or even being admitted. The delay in diagnoses can be detrimental to their life.
So, Chris, the CDC has quite a long list of top concerning health trends among the LGBTQ community, those that are at higher risk of obesity, eating disorders, people getting breast and cervical cancers and exams, as well as depression, PTSD, anxiety, you name it. So what specifically, in your opinion, has to happen for this to change?
Acceptance. People have to accept themselves for who they are and be proud of that. And then we need to be accepted by other folks. People need to feel love and acceptance, and they need to feel valued and not being afraid of being who they are. People need to exercise empathy, create a culture of acceptance for everyone, because no one wants to feel like they're less than, or if they do go to the doctor, they don't want to feel like they have to hide their full story, because not being able to give the full story will mean we're not being able to give them the full care and the proper care they need. Nobody wants to live in fear of retaliation or fearful of getting poor care. They just want to be accepted.
Chris, I can't think of a better way or a better message to wrap up the week. So thank you so much. Gigi, thank you again for joining us to talk about this important topic. Pride Fest is located at Thies Park at 47th and Oak Street, across from the Nelson Atkins Museum. The parade kicks off at 11 tomorrow on Saturday on Westport Road and Pennsylvania Avenue. So get out there and show your acceptance and your support. And thank you so much for being with us today. Don't forget, you can catch our shows anytime by logging on to Facebook, YouTube, and Twitter. Have a great weekend. We'll see you back here Monday. More than 40% of men are considered obese. From heart disease to COVID, many men face a series of health issues. I'm Jessica Lovell. Join us Monday as we kick off Men's Health Week and help them get and stay healthy.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now, everywhere podcasts are available.